Poor sleep, exhaustion, tachycardia, palpitations, dizziness, nausea, GI disturbance, brain fog, exercise intolerance. Sound familiar? Well, what you might not have realised is that all of these symptoms can be explained by disorders of the autonomic system. Our bodies, being essentially stuck in a fight or flight state, are never resting, digesting or healing as they should. If you saw episode 2 of this series, you'll have seen Dr Patterson discuss the viral debris he believes is responsible for triggering long-haul symptoms. We might or might not be able to do anything about the debris, but we can look into our body's reaction to it. So here's one of the world's foremost dysautonomia specialists, Dr Svetlana Blitshteyn, talking to myself and fellow long-hauler Dr Asad Khan about what's actually going on in the body on a reactive level and what we can do about it. I hope you enjoy. So thank you for joining us, Svetlana. I was wondering if, first of all, you could just tell us a little bit about your background and how you ended up in the field of dysautonomia being your sort of specialism.
I am a neurologist who specializes in autonomic disorders, and that includes common and uncommon autonomic disorders, but the most common ones are POTS, postural tachycardia syndrome, neurocardiogenic syncope, and orthostatic hypotension. And a lot of our patients had onset of these disorders after viral illness. So post-viral syndromes are very common in our practice. And now, of course, with long COVID, we see patients post-COVID, and it's not of a shocker to us and those of us who specialize in these disorders. But I understand, because of the sheer number of these patients, the medical community is quite overwhelmed and is learning new things for them.
Yes, absolutely.
Could you tell us what dysautonomia is on a relatively straightforward level?
So dysautonomia simply means abnormal autonomic nervous system, and it's synonymous with the autonomic dysfunction of any kind. It's not really a diagnosis, it's an umbrella term. And it's also a descriptive term, kind of like we say headache, but that doesn't specify what type of headache or why the headache is taking place. There is sympathetic, parasympathetic, and enteric nervous system, and each of these systems can malfunction, resulting in specific syndromes and disorders. So with this an umbrella term of dysautonomia, there are specific diagnoses with their objective criteria that have been defined. None of these autonomic disorders are subjective, and all have objective clinical criteria. The diagnosis relies on the assessment of blood pressure and heart rate in the supine and standing position. And that involves using a simple 10-minute stand test or a tilt-table test. So what is the autonomic nervous system? It's essentially an automatic nervous system that is essential to health and disease. It's how we adapt to the external environment and how we process any type of physical and psychological stress. And when the autonomic nervous system malfunctions, a person can develop a number of symptoms and signs that result in a disorder.
So you said there are different types of autonomic dysfunction. Which of those types are most commonly associated with viral infection or after a viral infection?
Well, I'll just say that there are many autonomic disorders out there. Thick textbooks have been written on this topic, but the most common ones in general are postural orthostatic tachycardia syndrome, or POTS, neurocardiogenic syncope, or NCS as we say, and orthostatic hypotension. And all of these can be seen in long COVID. The most common one observed after long COVID is the most common one that exists in general, which is POTS.
Okay.
And what are the symptoms that these conditions can throw out?
So diagnosis is made, as with any disorders, based on clinical features and objective diagnostic tests. In terms of clinical features, patients with POTS most commonly experience lightheadedness or dizziness, palpitations, racing heart, generalized weakness, and fatigue. And the important thing to remember is that these symptoms will be exacerbated by sitting or standing position and will be relieved by lying down. This positional nature of symptoms should alert patients and their doctors that a disorder of the orthostatic intolerance is present. And so if you are a patient and you want to have some preliminary evidence to present to your doctor, you can do a simple 10-minute stand test where you can lie down for about 5 minutes, check blood pressure, check heart rate, just press the button on your electronic blood pressure machine. And then you stand up and you wait 2 minutes, you press the button again, check heart rate, check blood pressure, and do this at minute 5, 7, and 10 while you're standing. And then you can record this data and present it to your doctor. And also don't forget to note how you felt. Were you dizzy or lightheaded while you were standing? Did you feel like you're about to faint in this 10 minutes? So these findings can help your doctor to determine whether you have POTS, neurocardiogenic syncope, or orthostatic hypotension.
That's brilliant. Yes, I was just contacted on Twitter, Svetlana, by a layperson who said that they went to their doctor because they thought they had POTS, and actually they were referred to a cardiologist who apparently had some experience with POTS, and this patient was told by this cardiologist, there's no way you have POTS, only young females get POTS. And, you know, obviously that's very concerning to hear that there's so little understanding out there. I'm just wondering, in the context of long COVID, what are the kinds of patients that seem to be getting dysautonomia?
Well, it's a very good question in general, and you nailed it by saying that many doctors associate POTS with being a disorder of young white females. Because in all honesty, you know, a majority of patients are women between ages 15 and 50. Of course, we have younger and older patients. They tend to be white, and they tend to be thin. So there is the, you know, stereotypes in medicine exist. However, a few years ago, I and a young doctor, we described a case report in British Medical Journal of an African-American male who had difficulty getting a diagnosis of POTS because most of the doctors he went to felt that he didn't fit the criteria. You know, he was tall and, you know, obviously not of the typical demographics. So it took him a while. And in one of the lectures that I give to residents, I actually have a, you know, his photo with his permission. He was one of the co-authors. He's a young doctor himself, where he, along with his residents or medical students, they're standing there as a group. And I say, who has POTS, right? And it's this guy that you wouldn't think would be in the category. Now, of course, these are less common in general, less frequently occurring in this population, but we shouldn't be, you know, excluding them because we have objective diagnostic criteria based on symptoms and based on objective testing. And he fulfilled all of them. So that exists in medicine. Now, with respect to long COVID, similarly, they tend to be in the demographics of women on the younger side, but there are more males there. And of course, there are all kinds of ethnicities and races. And in my case series of 20 patients that was just recently published in Immunologic Research, 70% were women. Mean age was about 40 years old, but the range was 25 to 65. And there were 30% men. So this is the demographic. And with COVID, it's very interesting. It tells us that nobody is immune, you know, because most of these patients were not, actually all of them, 100% of my patients were never hospitalized. They had mild, moderate cases of acute COVID. Only 2 patients had pneumonia treated at home. One patient, 25-year-old, was completely asymptomatic. She never had any symptoms. Suddenly, you know, in spring of 2020, living in an apartment complex with other people being infected in an area that had high prevalence of COVID, she developed shortness of breath, palpitations, severe fatigue, somnolence, she's unable to work from home. Her pulmonary function tests were abnormal. So the doctor said, this could have been COVID, because testing was never done because it wasn't available then. So the range is very wide, and nobody should be excluded based on the preconceived notions. But an objective diagnostic criteria with symptoms should be followed. And when we follow, criteria and scientific facts, we tend to make less mistakes.
Could you tell us, sorry, I was just going to say, Svetlana, could you tell us how debilitating dysautonomia can be? Because sometimes if people just hear the symptoms, but it's lightheaded, a bit dizzy, that's fine, that's not a problem. But I think what we're seeing in long COVID is that it can be really incredibly debilitating.
Sure. So 2 questions are there. How debilitating is POTS in general? Because before COVID, there were millions of people who developed what they themselves say, I have long mono, I have long Lyme, or I have long influenza. There were always people that I saw in my clinic with post-viral or post-bacterial autonomic disorders. So it can be quite disabling. There is a range. Some of our patients can participate in sports. Some of our patients work full-time as physicians, attorneys, and even, standing jobs. I have young people who work at restaurants on their feet. And then we have a spectrum of people who are very disabled and have difficulty walking to the bathroom. They're essentially bedbound. Now, some earlier research suggests that at least 25% of patients with SPOTS are so disabled that they're unable to attend school or work. But the numbers in my clinic were always higher, and I presumed that it was because of the selection bias. I tend to see sicker patients. And now we have new research showing that this 25% is higher. Maybe as high as 40% of patients are unable to function. Certainly, majority of patients need to do some kind of accommodations for their lifestyle, and work. Now, with respect to COVID, because this group, is still being studied. For example, in my case series, which I think today is the only one that's out there with some kind of prognosis, right? We have some case reports of 1 to 6 patients at most, but there are no prognosis there, markers. So for us, I basically followed them for at least 6 to 8 months. And what I noticed is, unfortunately, only 15% were able to recover to nearly 100% and return to work full time. And then we had 85% who still had residual autonomic symptoms of all kinds of range. Now, most patients in my case series did improve with treatment, and they self-reported improvement anywhere from 30 to even 85%. But did they return to normal or how they were before COVID? There was a small percentage. And 60% of our patients were unable to return to work. 40%, including those 15% that nearly recovered, were able to work part-time to full-time with accommodations. So that's based on my, case series. I think it's still small, 20 patients. Obviously, we need prospective longitudinal research studies to follow these patients. But interestingly, this kind of outcome certainly matches the outcome of POTS patients in general.
Right.
That's really interesting.
What about over the longer term? So obviously, COVID's not been around for that long. And, you mentioned that over a 6 to 8 month follow-up period, these were the outcomes. But prior to that, with POTS acquired for other reasons, what longer term outcomes are known?
Okay, so of course we have a few studies on long-term outcomes, and they come from Mayo Clinic, several of them. One study initially, many years ago, miraculously claimed that at least 80 to 90% after 5 years, they feel great. I and my colleagues who are doing this work, we didn't see that in clinical practice. So I think enough of us didn't see this in clinical practice that a second study from Mayo Clinic closely kind of resembled what we're seeing. And this was a study on teenagers that they followed them for years, maybe, 7, 8 years out. And they've noticed that only about 18%, less than 20% felt recovered. About 50 to 60% felt improved. And then there was, about 20% or less that felt that they're actually feeling worse. So that's what we have from that angle. And recently there was another study from Italy that used a Compass 31 questionnaire, which is a validated questionnaire to assess autonomic symptoms. And they noticed that there was a trend towards improvement with Compass 31 scores. But unfortunately, that didn't translate into improved disability and functional impairment in real life. So outside of long COVID, we view POTS as a chronic illness. Now, can it go away? Of course. We have patients, especially younger patients, teenagers, whose POTS resolved or almost resolved. They were very sick in high school. I saw them, they had PICC lines, they could barely eat or function, and then they improved enough to be able to go to college and have social life and do all kinds of things. So there is a subset of patients that will certainly improve. But I think a majority of patients need to view POTS as a chronic illness that can improve or worsen depending on the circumstances and depending on, external environment and so forth.
I see. So what is actually going on that's driving this? So in terms of mechanism, is it direct effect of the virus, or is it, as it's thought to be now in long COVID, an abnormal immune response to the virus that remains active after what is usually a mild initial infection and attacks different parts of the body?
Well, that's the $1 million question, right? We certainly don't have an answer to that. Part of the problem was that there was never enough interest in post-viral syndromes, not from the scientists, not from academia, and not from the NIH. And now with long COVID, NIH is committed, millions of dollars to go into figuring this out. They are running prospective studies. I have referred patients to them. So there is a big question mark. We just don't know. Now, in the world, there were different perceptions, especially in your country and some of the European countries. There was the notion that maybe a person is just stressed. Maybe they have some anxiety, PTSD, and they can be cured with all kinds of therapies. We never adhere to that because when you combine the current concepts of pathophysiology and the new findings of antibodies in patients with POTS, and then you combine with what we know about post-viral and now post-COVID syndromes, in my opinion, that the etiology is likely going to be autoimmune inflammatory process, mediated, whether by antibodies to various receptors on the autonomic nervous system or cytokines or cardiovascular receptors. This is yet to be seen, but that's my impression from being in this field for quite some time.
Go on, Des.
I was just going to say, what are the implications for treatments, and how do you treat these sorts of autonomic disorders?
So we start everyone on non-pharmacologic therapy, and patients are very educated these days. Even before they go to see a doctor, they already have read some articles that we write. They've been to groups. They know what POTS is. They've done a 10-minute stand test. They may know what mast cell activation syndrome is. And so the non-pharmacologic approach involves increased fluids intake. We ask patients to drink at least 2 to 3 liters of fluids per day. We ask them to increase sodium chloride or salt intake to at least 5 grams per day. And that would come from dietary salt and also salt tablets. We ask them to try wearing compression stockings up to their waist to compress the lower body. They can also try abdominal binders because blood is being pulled predominantly in the abdomen and pelvis. We also, in our clinic, put patients on gluten-free diet because we just completed a trial of gluten-free diet in patients with spots. My medical students are presenting this study this afternoon. And what we found is that gluten-free diet improved COMPASS 31 scores in the orthostatic intolerance and gastrointestinal symptoms domains, and that patients just feel better on this diet. So we use non-pharmacotherapy, and it's very important to add something that can be quite controversial. We do recommend some type of exercise and moving your body. This exercise includes recumbent bike exercise, rowing machine, or swimming. Exercise that doesn't involve a lot of gravity impact. So laying down all day in bed every day is something we typically don't recommend. Now, there are, studies from the chronic fatigue syndrome researchers that show that too much exertion, of course, can backfire because a second day of cardiopulmonary testing using exercise in these patients show that they actually deteriorate. They don't gain. That's why I advise my patients to start low and go slow. Don't overdo it, but also use exercise routinely. If it's 5 minutes on the recumbent bike every day, that's fine. That's what you start with. And then every week, increase the exercise duration by a few minutes. So exercise is very important because deconditioning secondary to illness is very common in our patients. I was the one who wrote a letter to the editor called POTS is not caused by deconditioning, because there is a notion that maybe these patients are just not exercising and sedentary, and that's why they're sick. That's not why they're sick, but certainly when you're sick with fatigue and exercise intolerance and orthostatic intolerance, and you add joint pain, muscle pain, of course, you're not going to exercise enough, or maybe you're not going to feel like moving around at all. So I encourage my patients to move, to walk around as much as they're able, and to do some type of exercise on the recumbent bike, rowing machine, or swimming.
Okay. At what stage would you advise people to introduce exercise, or would you say right from the beginning?
Well, it's a very good question. There again, we have no answers. This has not been studied. But we do have a few studies on exercise in POTS, and they have shown benefit. In one study in particular, which is known as the Dallas Protocol, 60% of patients were able to complete the study. Many were not. So this, again, it depends. You gotta create a program tailored to individual needs. But on average, some type of exercise routine is needed. Now, when should it be done? Of course, not when you have an acute COVID. Okay, that's, I think, logical to say that when people are running a fever and they're fighting an infection, that's not the time. But what happens after the infection is cleared, again, assuming that all of the virus is cleared, we have a loose end here too, we just don't know. Then some type of movement is advised. Staying in bed will lead to deconditioning, whether it's long COVID or long Lyme or whatever other cause for the autonomic disorder.
I was going to ask, could you just describe a little bit about what happens in the relationship between the sympathetic, the parasympathetic, and the enteric nervous systems? What is dysregulated about the relationship between those that creates the symptoms?
Right. So that's another good question. And what we know about pathophysiology of POTS, that it's a disorder of sympathetic overactivity. That means that the sympathetic nervous system is overactive. There is also evidence that Parasympathetic nervous system may also be underactive. So there is certainly an imbalance. And with respect to enteric nervous system, that's what controls gastric and intestinal and colonic motility. So as you can imagine, gastric motility disorders, gastrointestinal motility disorders are very common. Usually patients have significant GI symptomatology. And when they go see their GI doctor, the scopes are negative, ultrasound is negative, H. pylori test is negative. Then what? What you got to think about is gastric and intestinal dysmotility and even colonic. We have tests for that. There is gastric emptying tests, there are intestinal motility tests. That can be abnormal in our patients because, again, the autonomic nervous system controls motility, not only motility, also secretion, right? Secretions are being controlled. So things like dryness are very common, things like GERD. And then when you have abnormal motility and secretion, potentially that can give rise to small intestinal bacterial overgrowth and all kinds of other things. And when you add mast cell activation to the mix, because there is an overlap, at least 20% of patients with spots have mast cell activation syndrome. When you combine these two things, which are quite common in my patients with long COVID, there you have a multitude of various symptoms and signs that are not going to make sense to the average healthcare practitioner. So they're going to say, well, you're anxious, your mind is anxious, you're not sleeping well, oh, you have a mood disorder. But it's important to know, of course, brain is not separate from the body. It's part of the autonomic nervous system. With the autonomic nervous system, there are central controls that come from limbic system, that come from hypothalamus, that come from medulla and the vagal nerves and the vagal nuclei. So the picture is very complex. And certainly, in patients with post-viral syndromes, you can have anxiety, depression, OCD-like symptoms, insomnia and brain fog. That's not exclusive of autonomic nervous system disorder. That's inclusive. In fact, it's so inclusive that, recently my new review article came up. It was published recently in the Journal of Neurology called "Is POTS a Central Nervous System Disorder?" So when it comes to long COVID, I think it's going to be a prime example of the interaction between CNS, PNS, peripheral nervous system, immune system, immunologic, a contribution from mast cell, which is the allergy, and immunology arm. So it's going to be quite complex. What we also know, I want to mention this, is that quite a few studies are showing that the parasympathetic nervous system is anti-inflammatory, whereas the sympathetic overactivity is associated with inflammation. And there are certain genotypes and phenotypes occurring in populations that may make one predisposed towards, both autoimmune immunologic disorders and disorders of the autonomic nervous system.
That's really, carry on, Des. Yeah.
Sorry, we just both so excited by this. We've got so many questions. So I was just going to jump in there by saying, so are there things that you can do that help engage the parasympathetic nervous system, like breath work or like meditation? Are these sorts of things also useful when it comes to treating dysautonomia?
Well, if you're asking, have we studied this? No, we haven't studied. There are some small case series and isolated case reports of patients with spots being improved with various biofeedback therapy, neurofeedback, there is a study about certain breathing exercises. And as I always say, those have minimal side effects. So why not? Of course, everything that's going to increase the parasympathetic nervous system, that calming system, everything that's going to reduce sympathetic overactivity is going to be good for you. And it's going to be getting good sleep, meditation, exercise. It's going to be reducing caffeine intake. It's going to be reducing stress. But, you know, those things are almost like easier said than done, because it's a kind of a bi-directional relationship. How do we get good sleep? Well, sleep disturbance is very common in patients with spots and in patients with long COVID, because in order to get good sleep, you need to have a very balanced parasympathetic and the sympathetic nervous system. And if the pathophysiology of your disorder is increased sympathetic nervous system activity, guess what? You're not going to sleep very well. You're going to wake up frequently. It's going to be an unrefreshed sleep. It's going to be a restless sleep, perhaps with vivid dreams. And a lot of our patients they're waking up with palpitations and racing heart. So we have to be mindful. You know, as doctors, we can always say the good things, the right things, but we also need to understand that the pathophysiology of these disorders may prevent someone from doing exactly what is good for them. So how do I go about these problems? I go about these problems a lot of times with medications. We have some very good medications that can help with the sympathetic overactivity.
What are they?
I mean, we're doing the non-pharmacological measures here to the maximum. So yes, I think there's a long wait to see pot specialists in the UK, and whilst patients are suffering and they're doing all the non-pharmacological measures, what is it that family physicians can do for them in terms of pharmacology?
So most patients will require a medication. In fact, most patients who improved in my case series of long COVID patients, they were on some type of medication. And what the family physician can do, or a cardiologist, or a neurologist, or a rheumatologist, or an allergist, or even a gastroenterologist, is number one, you have to identify a problem. If you don't identify a problem, how can you treat it? And as you know, what happens a lot in medicine in general is that many doctors want to jump to psychological causes. And that's a very big mistake from the start. First, you want to follow the objective diagnostic criteria and see if your patients have POTS or neurocardiogenic syncope or orthostatic hypotension. Now, they may also have small fiber neuropathy. We didn't talk about that, but I think it should be mentioned that at least 50% of patients with spots have comorbid small fiber neuropathy. Same for mast cell activation syndrome. And post-viral small fiber neuropathy is also common. Already in my patients, some patients are testing positive for small fiber neuropathy. So it's important to add that one to the category of these post-viral syndromes. What can doctors do? Very simple things. Do a 10-minute stent test in your office. You don't have to do it. Your nurse can do it. Your medical student, your medical assistant. It's a very easy test. Document. We call it a poor man's tilt table test because not everyone is going to have easy accessibility to a tilt table test. Not in the United States, not in the UK. So a 10-minute stand test will do. If the patient tells you, oh, I feel dizzy, I'm about to collapse, that's very important. And then you can write in the chart possible POTS. That's what I do. Once you have that in, then of course you can follow the recommended treatment options. And everybody's going to start with non-pharmacologic measures because they're easy. The patients can do them themselves. There are no side effects, right? Except for those who have high blood pressure. If you have high blood pressure, then I have to reassess what salt and fluids recommendations to give. And it's important to mention with long COVID, it's very important for the cardiologist to do their part and make sure there is no pericarditis or myocarditis or, or pericardial effusion, because we don't want to overload them and put them in heart failure. So there is that caveat specifically with long COVID patients, post-COVID syndrome. But then you have to, assess, is the patient better? Very unfortunately, a lot of patients are not going to be feeling significantly better with non-pharmacologic treatment. So then we have to decide on medications. And we have a number of medications to choose from. The first-line medication treatment options for POTS are beta blockers to reduce the heart rate. But there too, there are many nuances here. So a lot of cardiologists just want to start the metoprolol 25 twice a day or carvedilol. It's important to note that in patients with POTS, low doses are needed. If the dose is too high, it's going to drop their blood pressure and maybe even their heart rate, because there may also have beta-1 receptor hypersensitivity. So they're very sensitive to medication. Start a low dose of a beta blocker, kind of a pediatric dose, and go from there. Increase the dose slowly. For patients who are unable to tolerate beta blockers, there are going to be some. Now, that's another caveat. Some patients have asthma and shortness of breath, and a lot of doctors are hesitant to start a beta blocker, being worried that it will exacerbate that. And my response is that in my experience, a low dose of a beta blocker has not been detrimental to anyone's respiratory status. If anything, our patients with POTS say that their shortness of breath is actually better because the heart rate is no longer, very high, both supine and standing. So beta blockers. Then for patients who are unable to tolerate beta blockers or allergic to beta blockers, there is ivabradine. Ivabradine is a very good medication because it works on different receptors in the heart, on the eye channels. And ivabradine has been in the US only for a few years, but you guys had it for a long time. It's a very good medication at a low dose. You want to start at 2.5 twice a day, similarly, and increase depending on the vital signs. Then we have medications like fludrocortisone. This is a volume expander that works on absorbing fluids and sodium at the kidney level. That can be very helpful. We also have midodrine, which is an alpha-1 agonist that helps the body vasoconstrict and prevent all this blood pooling that might be going on. Usually this is kind of the starting point. In that category of common medications, there is also mestinon, pyridostigmine, which is an old drug that we use for myasthenia gravis. But it's also shown to modulate the parasympathetic nervous system and improve blood pressure and heart rate in patients with POTS. None of these medications are controlled substances. Following that, this is the first line. The second line, we have other things like stimulants, Ritalin, Concerta, Vyvanse, Adderall. These stimulants can help those with low blood pressure, fatigue, and brain fog. They can be quite effective. Again, I start them at a low dose. Some people will respond to SSRIs, antidepressants, but in my experience, I never jump to that because quite a few patients are very sensitive to SSRIs. And unless there is severe depression, I just don't use this class of drug from the onset. Wellbutrin in particular can be good for patients with fatigue, brain fog, and maybe some depression or anxiety. We also have sympatholytics, the medications that can block sympathetic outflow from the brain level, and that includes clonidine tablets that we can use as needed, or clonidine patch. What else is out there? Out there is IV saline that can be used as needed. And in long COVID patients, some of my patients have used that to get over the worst kind of post-COVID symptomatology. We don't want to use them chronically and daily, because then that can lead to placements of PICC lines. And PICC lines are a risk factor for both infection and blood clots, because our patients, on top of everything, may have a higher risk of blood clots as well. So are long COVID or post-COVID syndrome patients. And in terms of kind of emerging therapies to tie into autoimmune, immune-mediated pathophysiology, some patients are able to have access to IVIG, or subcutaneous immunoglobulin. And in our country, those are very selected patients because it's a very expensive therapy and insurance doesn't authorize this easily. So these patients tend to be very disabled, bedbound, who failed all kinds of therapies, and who may be displaying these autoimmune antibodies in their blood or spinal tap or spinal fluid.
I think what's really coming through to me here is that this emphasis that we are seeing, particularly like you said in the UK and Europe, on bundling a lot of long COVID presentations, such as POTS, into the psychological bucket is just so ill-informed. And like you said, it isn't hard to diagnose. There are objective tests that can be done by the patient and by the family physician. And actually there's a wealth of medication and a wealth of non-pharmacological measures that can be tried. So these patients can be made better. So there's a lot of suffering that is needless. So thank you very much for that clear, consistent message that this is a physical illness. Jez, I wondered if you had any further questions.
I'm on mute. Yes, I did have one actually. If you had infinite resources, Svetlana, and you could do any research project you chose to design with regards to autonomic dysfunction in long COVID, what would that project be?
Well, fortunately, the NIH has designed that project, and it's a prospective study of patients with long COVID. They're going to come there and they're going to undergo all of the autonomic function tests that we have. They're going to have all of the serum antibodies drawn. They're going to have cardiopulmonary testing done to see what's going on. Tests like that were needed many years ago, and I think now it's going to happen. Hopefully, it's going to include cardiac MRI as well, to make sure that we haven't missed all these years some kind of small changes, pericarditis, myocarditis, some other changes that can be seen in some patients. And then ultimately, what we all want is better therapies. There is one trial that's going on right now in POTS of IVIG, and that's going on in Texas, and we'd like to see where it's going to take us. Because anecdotally, as I said, some of the patients have improved very well with immunotherapy when nothing else worked. Just this past fall, I presented a study at the American Autonomic Society on a few patients of mine who improved with some subcutaneous immunoglobulin. One is a physician whose career was completely derailed. She was homebound. She could not return to residency because of severe POTS. Nothing worked for her. And thankfully, subcutaneous immunoglobulin allowed her to return. She's now doing residency. Residency training was long hours. There are others like her. And that's very important that we follow that lead with immunotherapy. Of course, it's expensive. Of course, not everyone is going to qualify, but we want to have that option available for patients with severe disorder because they tend to be young people. And, in curing disability economically and socially and from all aspects is not a good thing. So it would be more cost effective for insurance companies to pay for immunotherapy than let young people have a lifetime of disability and unemployment.
Obviously, we completely agree. So one final question from me, which would be, if you had one thing that you could say to somebody who is maybe suffering with some of these symptoms which correlate with autonomic dysfunction with long COVID, and they've not been identified by their doctor, they haven't worked out. If there's one thing, one major tip that you have in your experience seen that has helped people, what would it be?
A tip to get better, you mean?
Well, anything they can do to help their symptoms or to stop making them worse, or what would the first course of action be for somebody who hasn't even worked out until now that maybe they have this problem?
Well, first of all, if you are someone who had COVID months ago and you're still very sick with fatigue, lightheadedness, dizziness, and just inability to function, you got to realize that there is a physiologic problem that's happening. Your best advocate is going to be you and a physician who understands these disorders. If you go to a physician who is dead set on the fact that nothing is wrong with you, that your EKG, cardiac echo, Holter monitor, they are fine. Your MRI brain is fine. Your blood tests are fine. Then you must be fine. You are at a very bad spot. I talk about that specifically to you guys because I have patients from UK. So I'm quite familiar with what's going on there and what's going on here. And it's concerning to see that, that in your country, there is still this outdated notion that somehow with your mind, you can recover. It's like asking a diabetic to recover without the use of the insulin. So it's a physiologic problem, and I always say, you only need one doctor on your side. They don't have to be specialty care. They don't have to sit, at a famous hospital or institution doing the autonomic labs. That ship has sailed. This was in the past when patients waited for years to get in to see a specialist, only to be told to increase fluids and salt intake. I don't think that's going to fly anymore with long COVID, because all of the physicians now are going to become experts, whether they want to or not. And educating yourself as a physician is not hard these days. We have articles, we have organizations that are running courses for autonomic disorders. You can read, you can read as a doctor and do the best you can for these patients. And if you don't know, you can certainly ask someone who does. But I think keeping patients sick and constantly telling them to exercise or see a therapist or get better sleep, when their heart rate is running 120 beats per minute at night, they're not going to get any better sleep unless you address physiologic abnormality. That's not good care. So hopefully doctors in all countries can join us and get on board with the autonomic disorders.
It's just the basic stuff, isn't it? It's listening to your patient and looking for a diagnosis. And that's what we were taught at medical school. And that's been forgotten. And instead, anything where the tests are normal is automatically labeled psychological. And that's really, really sad. And it's a disservice to our patients. I can't thank you enough. I mean, that's such a powerful yet simple message.
Well,
thank you so much.
Thank you for having me. I hope that was helpful.
Monumentally. And also the other thing I'd just like to say as well is, there's a lot of people who will see this. There's a lot of people who are suffering with dysautonomia and who are getting blank faces back from their GPs. And just to be told that they're not going mad, and there are things that you can do, and there's a reason behind this, is so incredibly important for them. We've got 1.1 million people in the UK with long COVID symptoms. It's huge.
Yeah, absolutely. And having a positive attitude is great. We certainly believe in that. At the Dysautonomia clinic, at my clinic, we have a clinical psychologist who works with our patients. But it's not going to be enough it's not going to be enough to get people better because it's not their fault. It's not their body's fault. It's the abnormal physiology. We can help that with medications and non-medication treatment options. Most medications are not controlled substances. So primary doctors, family doctors don't need to worry about prescribing. If you're not comfortable prescribing Adderall, that's fine. We have many other medications, standard, routine, safe medications that are used in pediatric population to help with these issues.
Thank you very much. And as Jez was saying, this is really going to resonate with so many patients out there, but I think it's also going to be very educational and empowering for physicians out there as well, who maybe really want to help their patients, but just don't know where to start when they get these patients with long COVID with non-specific symptoms months down the line. So, this has been really, really helpful, and we can't thank you enough.
Well, thank you for having me. Good luck to all of you. And let's hope that this COVID pandemic brings some much needed answers to post-COVID dysautonomia and post-viral dysautonomia in general.
My feeling on the dysautonomic side of things is that we need to do whatever we can to calm down our body's fight or flight reflex. Personally, I've found breathwork and meditation to be hugely helpful, as well as trying to modify my environment to remove stressors and spend as much time outside as possible rather than being indoors and stuck inside my own head repeating those same old thought patterns. I'm wondering why pacing is so essential for long COVID, because it's really one of the few things that helps our body drop out of that sympathetic response and engage our parasympathetic nervous system. So think about what's going on in your life and what you might be able to adjust to create more zen in your world. It might just help more than you think. Because tempting as it is, it's not always about trying to medicate the hell out of the condition. Till next time.